education at Hamilton Health Services and has an interest in the pathophysiology of sepsis and in particular the use of biomarkers in the diagnosis of sepsis. And she was awarded an award in 2018 from the Global Sepsis Alliance in recognition for her contribution. She's a past president of the Canadian Critical Care Society, and today she's going to talk to us about deteriorating patient strategies in Canada. Please welcome Professor Fox-Robichaud.
Thanks, Daryl. Good morning, everyone. Welcome from Canada. I've been here since Saturday afternoon, so I'm over most of the jet lag, but thank you. Let's just make sure my clicker's going in the right way. It's Thanksgiving weekend in Canada, so I'm missing some family time, but happy Thanksgiving on behalf of Canadians. It's our harvest feast time. What I'm going to do over the next half hour, and I want to leave some time for discussion, I think we in Canada are really quite envious of the work that's been done around rapid response systems and medical emergency teams in Australia particularly. But I want to give you a little story of how your great work led to some, what I think is some innovation in Canada. We often say in Quality in Canada that we borrow or steal shamelessly, but acknowledge graciously. And so we've acknowledge the work that you have done, but maybe have taken a different direction. So I'm really going to spend some time talking about the implementation in my home province, which is Ontario. Some of the rationale for why my hospital in particular went forward with track and trigger system and an early warning score beyond the single calling criteria, and to understand some of the impacts of delays in activating from the afferent arm of early warning systems. So even though my work is in sepsis, this is the quality work that I do in the hospital. Some fast facts about Canada. We're a little bigger and a little more populated, but not by much. 3.7 million in the last statistics, 40% of which live right in this province, and indeed most of it right near the Great Lakes around Toronto area, which is our largest city. Healthcare in Canada is publicly funded through the Canada Health Act, but each province determines how that money is controlled. So our tax dollars go into our healthcare, and so there's wide variation in how, and I'm really going to talk about some of that. We do have some national reporting back in terms of quality and safety. It's through the Canadian Institute of Health Information. We get data on sepsis among others, but some of the ICD data comes back in, so we know our cost data per hospital, for example. And the other thing that I'm not sure many frontline healthcare providers are aware of, but many hospitals, in fact, I would say most hospitals and outside facilities have to carry insurance. And in Canada, this is done through a group called HEROC, which came out of the fact that some of the regular insurers in the early 60s refused to insure hospital systems. But they also provide some data on why they have to insure, and I'm going to circle back to that in a bit. All right, so ICU capacity really varies across Canada. This is data from Rob Fowler, who's the current chair of the Canadian Critical Care Trials Group. This was done not after the SARS, but after the mid-2000s flu pandemic that we had, the H1N1 pandemic, looking at the number of available beds with ventilation. And you can see that up in the territories, which is very scarcely populated, few beds, but when you get down into the higher areas, this is city of Calgary, this is Toronto area down in here, and that's where I live. There is a fairly dense number of beds per thousand population, and capacity is larger. So with that background, let's talk about why critical care response teams came into at least the province of Ontario. You may or may not remember that Canada in particular, and Toronto specifically, was rather badly hit when the SARS epidemic, and that is because we have a vast multicultural community, many of whom were coming back and forth from China where the outbreaks occurred, And so we ended up having to close hospitals. It was the same time that the deputy health minister was in place, and he asked the infamous question, how many ICU beds there were in the province of Ontario, and nobody could answer. And that started a process that resulted in a review of all of critical care practices that came out in March of 2005. Now, if you guys remember, when did the Merit study came out? Just after this was published. And so out of that report came 7 different strategies. Amongst them was a government-funded introduction of critical care response teams and an information system to load all of the critical care data. So the change from 2015 to now is that I can go onto that system and tell you exactly how many ICU beds are, how occupied they are, how many ventilators there are, and not only for the major units, but the minor units that we call level 2. Okay? There was an agreement between a nascent group of educators called at the time the Canadian Resuscitation Institute and the Ministry of Health within the province to provide health professional education, not only of nurses, and we have respiratory therapists in Canada, but also to train a number of community physicians to be able to better respond to critical events. The response team model that was produced was primarily a physician-led model. We have 4 academic pediatric centers. They were also funded, and the larger hospitals that had at least 15 beds in them at the time. And out of that, in October 2005, we began developing a training program that began training both the providers and physician educators. And it was really novel in the time in that we had trained primarily the physicians to educate nurses and respiratory therapists about how to respond to critical events on the ward. So it was unique in that way. And this is the course that we ran for a number of years, and my site still runs, which was a 2-day, 15-hour course. Participants at the time, and for the most part, are still mostly RNs, some respiratory therapists. We did a mix of a course in which we had didactic lectures, some role-playing, hands-on, and simulation, and we introduced a number of strategies, how to manage a crisis, SBAR communication, triage decisions, airway, breathing, circulation, all of the basics that we might expect to see out on the ward. Also discussing CNS changes, ethics, and how to manage conflict. And since that course began in June of 2006, we've probably trained over 500 nurses and respiratory therapists from more than 40 hospitals across the province. And that course has been taken elsewhere across the country to train, particularly think in Edmonton and a bunch of other places out west. But it hasn't been yet universally accepted, and now the ministry has cut that back with some concerns to 5 online modules, which I'm not sure provides the same degree of education for the providers. One of the things, this talks a little bit about the simulation. We built simulation into this course and started with very simple things from respiratory distress and hypovolemic shock, and then progressed to increasing complex patients. And we always told our trainees, these are the first 6 patients you're going to see out on the ward. These are the ones you get to make the mistakes with, and then we'll let you go beyond there. Okay. The course has generally been well received. We did some qualitative data with the participants over the first 400, and although they found the simulation stressful, it certainly allowed them to experience what it was going to be like for a call. In our center particularly, it was an opportunity for some of my nurses to be able to take and continue to be instructors in this course, which they've continued to do. The other thing that came out of this ministry funding to the tune of about $1 million Canadian per hospital per year, that's continued since 2005, was a broad education of the entire hospital. So one of the things that we did learn from Merit was the fact that there was perhaps not enough penetration of education of the wards about when to call, who to call, why they should be calling, and that the ministry made it very clear that there was money to be spent in educating. And even to this day, part of our new employee orientation is all about making sure you call the response team. We taught some concepts, and I know that there's a beautiful course that's being run within Australia and New Zealand right now, but we taught some things that we as physicians often practice, which is concurrent management. That is, you may be doing treatment and investigations and starting therapy before you actually get the whole picture. A focus on airway breathing and circulation and going back and looking at what you've done, but also highlighting SBAR as a communication tool and emphasizing to the response team members, but also teaching them how to ask for that information from frontline staff who may be calling them. The other thing that we've done that was probably a bit different from my understanding anyway of how the MET teams run within Australia is that we had a certain amount of triage in all of this, and it was clear that we were a consulting service, not a takeover service. And so we relied on the team, that is the primary care team that was involved in this patient and knew this patient best, to be at the bedside when we were there. And then we made a decision between the response team members with the intensivist of who was going to have to be admitted, the admit to the ICU. We're going to scoop your patient has a life-threatening condition, versus we're only going to be there to help, maybe make a decision about goals of care, discuss with the physician whether it's worthwhile for this patient to be admitted, but unlikely to transfer, and really putting the onus back on the team to manage that patient. And that goes into, that triage ABC actually goes into our information system. So when we developed that triage system, Randy and I went back and said, okay, Randy Wax and I looked at what was the triage criteria. And so now every time we see a patient within our system, it is reported what was your triage level when you initially saw that patient. So we have data from the ministry for this. One of the things that happened out of all of this and was that I took our team and particularly gave them some projects to make them engaged not only in the care of the patients out there, but understanding why they were doing this care. So this is just 4 examples of some work we were doing. The first is the focus on sepsis, and I would suspect for the people out here, you know, every 1 out of 2 consults you see probably is a septic patient, right? It's so common. It's often the most common reason we're going to see those patients, either because they were admitted to hospital with sepsis or they've developed hospital-acquired sepsis along the journey. When we started, our cardiac surgical intensive care unit was expected to be following all of these patients. So that was the other thing that was mandatory when we came out of this, was 48 hours of follow-up of every ICU discharge. Well, how many cardiac surgery patients are being discharged within 5 days? So we actually went back, provided the ministry with data that said, we don't need to see every cardiac surgery patient coming through the journey, but there are a cohort of patients that we do need to see after the complex patients after cardiac surgery, and this was just data showing that. Sepsis education in terms of why we're there, and then a specific drill down on the respiratory arrests, which we thought were still occurring at a frequency which was a little higher than we would have liked. And we looked about 50% of those respiratory arrest calls that were still occurring, and we still had to report to the ministry, were in fact a failure to call us early enough. And so what were we going to do to improve that respiratory failure? So now, as this mature system 15 years later looks like, we still report every cardiac blue. Our hospital audits every cardiac arrest. I know Ottawa audits every cardiac arrest, every respiratory arrest, goes back and looks and say, what could we have done different? How could we have educated that unit different to make a difference in terms of the outcome for those patients? I was fortunate to have a bright young, initially medical student and then medicine resident who took on some of this data as we were starting to collect it. And this is Ben Tam's original publication looking at end-of-life care, and there was some other work that had come out of our early response team work in Ontario looking at end-of-life care. And it was clear that when there was a discussion about change of goals of care, which again we report provincially, there were less transfers to the ICU, and more often there was a scope of treatment form completed, that is, that we made a decision to allow natural death rather than ending up coming to the ICU. More often palliative care was involved, and importantly, the response team was aware of the patient was at the end of their life, and therefore there were goals in terms of the fact that the patient often died within 24 hours after being seen by the response team. And yet prior to this, there had not necessarily been a full goals of care discussion by the team members. So this is one of the other things that we've learned over the last little while. In the middle of this implementation of the response team, we actually developed a pre-printed order set which was around scope of treatment. We call it our post-orders, physician order scope of treatment. It's undergone some revisions, but what essentially happened out of that is pre this implementation, there were very few patients who actually had a goals of care discussion. Once we implemented this goals of care order set within the hospital system, we were able to see that there was much more effective discussion. We based that discussion on the single question, does anybody know what the single question is? Would you be surprised if 1 year later this patient was still alive? And if the answer is yes, I would be surprised, then that patient should have, during that hospital stay, a goals of care discussion. So that's the surprise question. So we, like you, had single calling criteria when we started all of this. And in fact, we shamelessly borrowed the calling criteria from the Met teams in Australia and New Zealand. But in my center in particular, I was still getting far too many code blue calls. And the question was why? Why were we still getting code blue calls? Purpose of this was to reduce the number of in-hospital cardiac arrests. It was to decrease the number of patients who needed an ICU bed. The goal was that about 25% of our consults should perhaps require an ICU bed, but we were still missing. And so an opportunity came up, and here was my pie in the sky dream. Imagine if in-hospital cardiac arrest on the non-ICU wards was a never event, right? The US likes to talk about their never events. These things never occur, but of course they do, and they don't get paid for them, but never events. But in our hospital insurance payout, failure to appreciate a deteriorating status was the number 2 reason that hospitals had to pay insurance. The number 5 reason was a hospital-acquired infection, hence our calls for sepsis. And number 6 was an inadequate triage or assessment reassessment, which speaks to the emergency department, right? So what could we do better? And I happened to be speaking to a group of surgery residents, and one of the surgery residents came up and said, I've been reading about this modified early warning score that's come out of the UK and Chris Sube. She said, I'd like to do it. And I said, well, okay, well, if we're going to do this on the surgery wards as a pilot project, you're going to go talk to my friends in informatics, because we had an electronic medical record at the time, and we're going to do this within our electronic medical record. Now, this was 2008, 2009, which seems only a decade ago, but remember, in many places, they did not have electronic medical records, and I suspect many of you still don't have electronic medical records in your hospitals, right? So it was a big step for us, and it hadn't been reported before. And so it aligned with our implementation, and what she did was a mixed methods. This is sort of a poster that I don't expect you to read, but the long and the short of it was, even with this pilot work, there was evidence of a number of things. First of all, the infamous respiratory rate was still charted incorrectly, 16 or 18, and we hadn't fixed that, and we still haven't fixed that. The second thing was that we actually did have some impact on the cardiac arrest, even though it was a small one. It went down by 50% from the previous year on those wards, surgical wards, rare events, but still happened. And it sat in the background as the modified early warning score for over a year until the chief nursing executive came to me and said, we're going to put this through the whole hospital. And I said, okay, here we go. And the first thing we did was we looked at the data. And if anybody's ever looked at this literature, you know that the modified early warning score has some significant limitations, which is why the UK has constantly revised their score that currently exists, because they've realized they've missed some essential things. The biggest thing from the modified early warning score is they weren't tracking oxygen saturation, which is kind of important when you're looking at respiratory decline. So we looked at the best of news, the Vital Pack, which is basically news in a small modified version, looked at the respiratory rate data, because there's a difference in the respiratory rate charting, and there was some literature to say really greater than 20 in an adult when you really start to worry. And we added a delirium assessment in there, partly because that had been a quality improvement strategy throughout the entire hospital. It was a bit of a guess what we were going to provide for that score, but we took that spread out of alert, and that's because my hospital in particular is a neuro hospital. It is the regional referral for neuro, and not everybody's alert, right? So we were looking at a change in neuro status. And for those of you who haven't seen a track and trigger system, the basic thing is you look at your vitals, you add up the score, and you plug it in. Now here's the beauty. If you do it in an electronic medical record, you don't rely on that frontline nurse having to do the calculations. They just have to plug in their vital signs and the score pops up. Okay? And so we put up a pop-up system score, and it pops up and it tells the nurse what to do. Now that requires the nurse at the bedside doing what the pop-up says they're supposed to do. But it was in there, and as a result, we studied it. And we were fortunate because as we were implementing it at one teaching hospital, the other teaching hospital had yet to have a ministry-funded response team. But we wanted to get the early warning score up and running. And there was an opportunity to look at a large number of admissions. And so what we have now is a database of about 7,000 admissions over a 6-month period in 8 medical and surgical wards, in which we've been able to go back and look. This is work that was published. This is Ben's work, the next paper. And what he was able to demonstrate, is that these patients in general who suffered a critical event, and now the literature defines not just a cardiac arrest, but you come into hospital, this is an unexpected death. You may have a goals of care discussion before all of that. Or you ended up in the ICU. You were admitted to ward. You weren't planning on having an ICU admission. And so that 3 components of a bad outcome coming into hospital. And we were able to demonstrate those patients were more complex, they had more critical chronic diseases, they were more likely to have heart disease or lung disease or renal dysfunction or dementia, malignancies, and many of them had allowed natural death prior to admission. And their early warning scores, although not above our threshold, were still statistically higher than we had expected. When we drilled down into those admissions, this is why track and trigger systems may be beneficial for sepsis, is that most of the time those requiring an ICU admission were admitted because they had infection, which infection and ICU admission in my definition is sepsis. The other thing in all of this, when you implement a track and trigger system, is to look at the workload. And people often report this as the area under curve, which is the sensitivity over the specificity. But in fact, there was a lovely paper talking about why that may not be the best statistic when you're looking at early warning scores, but rather looking at a workload, the number needed to evaluate or to see to prevent one critical event. And so when we looked at our data and the thresholds of our Hughes score, we were able to show that high risk positive predictive value was high, and you only needed to see less than 3 patients to prevent one critical event. And I will tell you, the team comes running if they hear that score greater than 9, because they know that there's a 1 in 2 chance that that patient's not going to do well. Subsequently, with some help from our colleagues in Ottawa, we've gone on to validate this, and not only that, but compare it to now the UK standard of News 2. Ken, were you there when I asked Chris that why didn't they have delirium in their early warning score? And the next thing that I know, they've turned around and they've added a delirium score into News 2. So they put it with a score of 3, but we compared head-to-head in a large database of cohort of about another 5,000 patients in Ottawa, and we were able to demonstrate that the two scores perform pretty much the same in terms of sensitivity and specificity. Our number needed to evaluate is a little less than the News 2. But the sensitivities, the specificity for Hughes is greater in terms of its prediction for hospital mortality particularly. So I'm going to shift gears just a little bit again now. Daryl, I'm doing okay for time? Okay. And talk about this current paradigm between the patient, the AFRID arm, plus or minus an early warning score, single criteria, track and trigger, whatever that happens to be, and the rapid response team. And really where this focus is, we come when they call, but do they call in a timely manner, right? Do they look at that vital sign and say, is this really abnormal? Do they look at that track and trigger score and say, should I really call the response team? We still, 15 years later, still have some pushback out on the wards. Why did you call the response team? The response team doesn't need to call, those sorts of things. So there's a bit of a culture thing that we haven't fixed. And as Ronaldo said at one point, it's an important principle that rapid response teams and all critical care interests, early, better, right? So this is work done by one of my graduate students who actually went back and looked at all of the response team calls for a year and was able to time when the vital signs were abnormal in our system and when they actually called. And who's it? I know there's a few nurses out here who've practiced on the wards in the past. And those vital signs get put on a piece of paper. And sometimes they sit in your pocket for a period of time. And we were able to demonstrate that rather than putting them into the system, triggering an early warning score, they would sit in the pocket. And then they would sit for a period of time before they actually called the team. And so we looked, and we had found patients who were 24 hours later before the vital signs got into it. So that's what's happened. They were on their pocket, they went home, they came back in the next shift, and then they put them into the early warning. Okay. So what's the critical time point? In our data, anyway, it's 4 hours. If you 4 hours, the odds of an ICU transfer were 3 times greater. Odds ratio 3 times greater. It didn't really change beyond that. That 4-hour time point was critical. And it wasn't just, death wasn't the outcome. It really was this ICU admission for the composite outcome. And if you adjusted for things like, okay, how chronically ill is this patient, whether the Hughes score was greater than 5, it still played out that the odds ratio for ICU transfer was statistically significant, adjusted or unadjusted, and the composite outcome was statistically significant. So the long and the short of it is, if that frontline nurse waits 4 hours or more before they enter their vital signs and activate the response team call, there's a greater risk that that patient's going to end up in an ICU bed, and if you put that all together, may die during that hospital admission because of the delay in activation. So what's the solution for that? There are many solutions. This is one that we've taken. Rather than putting that vital sign on a piece of paper, keeping it in your pocket, then when you've got time to chart, put it into the record, what if we could make you do this at the bedside? And what if we, rather than doing it at the bedside, could push that vital sign automatically into the medical record? Well, we have a lovely company that we've been working with where we've developed a smartphone app. And that smartphone app we developed with the frontline staff. We put alerts on it. We push it to a phone that the response team has. We push it to a phone that the charge nurse on that ward has, because I don't know about your hospital, but our hospital, where do all the rookie nurses go? Out to the medicine and the surgery wards. That's where the new grads go, right? And they may not feel as comfortable about activating people. Okay? And so we created these roles, the bedside nurse, the charge nurse, the response team, and notifications are sent automatically to that. No delay in reporting the condition. And the beauty is, now the response team gets that activation. They know exactly what vital signs are abnormal. And they know that they can come and activate. So we specifically have done this. This is the longest pilot I've run in a while. It's been running since early January, but the long and the short of it is we've reduced the cardiac arrest rate by 61%. And these are my post-op cardiac surgery patients, the highest risk for having a post-operative cardiac arrest in this, and reduced it by 61%. So in my hospital now, hearing a cardiac arrest with the calling criteria in this activation is a rare event. So what are we learning? The first thing we learned, if you're going to do this, the vital signs have to be mandatory, because I don't know why, but sometimes they just don't want to enter them all. And even if the vital signs have to be Q5 minutes, most of the vital signs have to be mandatory. You can't get out of that page. I had colleagues try to do the same thing in another one of our teaching centers in Ontario, but they didn't make the vital signs mandatory, and there was a lot of gaming. Oh, I'll put this vital signs in now, but then I'll go back, and it never activated a score. So that was the first thing. The second thing is endpoints are just not cardiac arrest. We're busy. We've made a change to the threshold because we didn't do a lot of interventions at 5, so we've upped it to 6, but cardiac arrests are now rare. Right? We've gone down to 4.2, and it may not be as beautiful as that last graph I think I saw from Ken, where it was down to like 1 to 2 per thousand, but we're 10 years behind you guys, right? Workloads are magnifactual. The afferent limb not calling is still an issue. Patients with chronic conditions who chronically have an elevated score, we've dealt with on an individual basis, and we recently changed the thresholds, but every time I hear a cardiac arrest, I say, okay, what happened with those patients? Finally, just to wrap up, these early warning scores work in the emergency department, and if you know the UK culture now, it's not just in the emergency departments, it's in the family doc's office, it's everywhere. But we were able to show that it was important for picking up those patients who were infected, that the area under the curve was relatively similar. This time it was between Hughes and News 2. But many times these patients were sitting in the emergency department, sent to a ward, and triaged inappropriately. Like they weren't seen within the 15 minutes. They were sitting in our good old Canadian emergency departments for 2 to 3 hours before they were seen by a physician. And again, when we looked at this specifically between Hughes and News 2 with the Ottawa database, again, sensitivity is fairly similar between the two, specificity much better for Hughes 2, and I'm not sure if we drill down what the difference between the two of them is. So in conclusion, access to critical care resources varies across Canada, as is the implementation of response teams. Ontario's been fortunate or unfortunate that the SARS made a huge change to how we provide critical care services within the province. That included the development and training of reporting deterioration outside of the ICU. Other provinces have taken this up with variable amount, but not necessarily the same training and infrastructure that we have. And based on the evidence from UK primarily, at least at my center, and now the province is starting to think about electronic early warning scores, single criteria, may not be the answer, but improved sepsis recognition is one of those solutions. And with that, I thank you, and if you feel like a long journey, come to Vancouver in 2021. We're hosting the World Congress there, and we're looking for a big party. Thank you.
Thank you very much for that. We've got time for one, maybe 2 quick questions. If anyone's got a pressing question, just pop up your hand, and there's some roving mics. Yep.
Yeah. So in that pilot project, we do that. We've learned from what's happened in the UK. So one of the things that we had set was monitor your vital signs more frequently if the score is starting to creep up. We're not sure that's happened. So we've now driven that with an escalation of care policy. We've now changed the pop-up window that comes that says you must do vitals Q2 if your score is this, you must do vitals Q4, or if the score is this, you must notify the team if the score is going up. Just don't leave it with the nursing staff. Call. For you guys, it would be the registrar, call the house officer, come to see the patient. We still find instances where that doesn't happen. In my ideal world, there would be an automatic war room or whatever that would happen to be, where all of the vital signs would get pushed to the response team and we'd know who was sick in the hospital. We do a lot of surveillance, but it's not perfect yet. And I'm not sure anybody's got the perfect system. The other thing that these scores don't do well is they don't account for things like social determinants. They get the chronic comorbidity, but we don't add scores in there for chronic critical illness, who the patient's coming from. I've got students right now looking at some of those social determinants because I think there's evidence from Dana and from Matt Cherpick and the group in Chicago that if you start to do a bit of machine learning in all of this system, you have an even stronger, more valid score to be able to predict who's going to deteriorate in the hospital.
One more question, John. Speak nice and loud.
So, as I said, the ministry funds nurse and physician. We've managed to cobble a respiratory therapist into that system because we have respiratory therapists. They have other tasks to do, but they're primarily there. We've enhanced their scope of practice, and within North America, respiratory therapist scope of practice is actually broader than a nurse's scope of practice in terms of the technical skills that they have. They primarily focus on the cardio-resp system. So nurse paid by the government, physician paid by the government, and depending on the center, you may add a respiratory therapist into that call, although the respiratory therapists often come to the calls. We have medical directives for our team, so the nighttime they can do a lot of independent work because a junior house officer may not know as much as an ICU nurse who has 10, 15 years experience. And so they often direct the care, but that's what we currently run. And the critical care physician during the daytime working hours, that critical care physician has no other responsibilities other than to the response team, and bed management for the ICU is the only other role we have. It varies a little bit from center to center in the province, but for the most part. Now, there are a few centers where it's primarily nursing or respiratory therapist led in some of the smaller hospitals. They've managed to put that model together, but all of the funded ones are nurse physician led.
Thank you. Can you please join me in thanking Professor